Excellent. I'd like to welcome everybody to our Epworth Eastern Neuroscience meeting, and particularly to Professor Heinz Wiendl, who's from Germany, who is an immunology expert in the area of neurosciences. So we're very lucky to have you here today, and I'm pleased that you've come to join us and give us some more insight, particularly into areas of MS, but other forms of neuroimmunological diseases. So thank you. And also particularly thank you to Biogen, who've helped sponsor you coming out to Australia to help educate us a little bit more in the area.
Yep.
Thank you.
So thanks for the introduction, and I'm going to start right away. I realize that a couple of colleagues are in the digital atmosphere somewhere. I can't see them, but obviously you can see me. And I'm not sure how much you can see from the slide I'm going through. I'm trying to be as explaining as I can. Nonetheless, the slides are having some data that help me to kind of substantiate what I'm saying. So I also realize that not all of you here listening are experts in neuroimmunology, but it's probably also relevant for, let's say, other fields in neurology. And what I'm going to dig a little bit deeper in today is why are we doing immune phenotyping? Why does that matter for understanding multiple sclerosis better? So let me start off with this slide that shows you a little bit of a personal cartoon in the world of inflammatory demyelinating diseases. So you could ask yourself why there is affection of certain areas in the brain in inflammatory demyelinating disorders, and you could ask yourself, well, why are some of these diseases restricted to the optic nerve while others can affect basically everything in the central nervous system? So you have monofocal chronic relapsing, or you have multifocal but monophasic diseases like the spectrum spanning from ADEM to recurrent isolated optic neuritis. And the question is, would that be different immunopathological traits? So what's actually distinct phenotypes, and is there within one entity, and the major entity most research is dedicated to is multiple sclerosis, where you have probably the biggest heterogeneity where, how, and how long certain areas of the brain are affected. Our approach that we've established over the last years, and I think that is something relevant to many areas in neurology, is to better understand the neuroimmunome. So how is the crosstalk between the probably two most complex systems in the organism really working, and how can you measure that? And our work is mainly dedicated to really assessing the human situation, and we're trying to assess as deep as it's possible the immune system. And this in-depth characterization combines different elements. One is to assess the immune system and its players by different technologies, including a very deep cellular analysis of the immune system, plus combining that with all sorts of other things, including clinical information, metabolic information, transcriptomic information. I'm showing examples in a couple of the next slides. So what we believe we can get out of that is insights into immunopathogenetic processes in multiple sclerosis, but to really appreciate what's going on in multiple sclerosis, you're using a lot of control diseases, not only in the world of neuroinflammation. You can actually better personalize or individualize therapy and maybe derive from that novel therapeutic concepts. What is absolutely essential to be able to do that, and that has actually basically taken the last maybe 10 years to build that up, is you have to have well-curated cohorts. So cohorts that you have, let's say, good information on. You have a biorepository, and you have those cohorts being available either in a cross-sectional, but ideally also sometimes in a longitudinal fashion. So I'm working in Muenster. Muenster is northwest Germany. Germany has a pretty good culture in assessing patients also via cerebrospinal fluid analysis. So every patient basically entering neurology is getting a spinal tap. So what we've done, basically as all comers in my neurology department, we have assessed cerebrospinal fluid, but not just with the conventional parameters. We have used flow cytometry. Flow cytometry is a technology where you assess the cellular components, and you do that both in the peripheral blood and in the cerebrospinal fluid. That is quite unique because it can instruct you on a more detailed immune signature in addition to helping establishing the clinical diagnosis. The other very important cohort I'm touching on is the so-called national MS cohort. German national MS cohort, something like a mission started something like 9 years ago, where we attempted to assess early MS patients that are without therapy, but a diagnosis established not more than 18 months before inclusion into the study, and followed up longitudinally for 10 years with a very deep assessment each year. And we have a sub-cohort where we do a deep cellular immune phenotyping. So the question here is there something that you could actually denominate as a MS-specific signature, and is there within the multiple sclerosis, let's call it spectrum, also something you can measure in terms of the heterogeneity? We've learned over the last years that not only in specific neuroinflammatory diseases, but maybe also in other neurological diseases, that genes and environment play a very dominant role, and you need to control, especially when you do this phenotyping approaches for those things. And one particularly interesting cohort is a so-called twin cohort, where we have monogenic twins that are discordant for multiple sclerosis. So they have the same genetic setup, they have pretty much the same environmental conditions, they were raised, but they are discordant for multiple sclerosis. And what we applied here, that is a cooperative work with the Munich group that has acquired this cohort over the last years, is again to do this deep cellular immune phenotyping. And as I said, those results can only be appropriately interpreted in the presence of various controls. Control cohorts such as rare neuroimmunological diseases, Rasmussen, SUSAC, NMO spectrum disease. So things that you could call colibris, but they are very instructing in terms of differentiating maybe the immunopathogenetic traits and to understand the heterogeneity. Autoimmune encephalitis, and last but not least, you need healthy controls. I mean, you need age and sex to match healthy controls. This is a slide that is basically unreadable. It shows you a matrix. When we started this mission, I called this whole concept and project the so-called mega immune phenotyping, and people in my lab were laughing about me, and what we established, something like the matrix, a matrix of a 10 times 13 flow cytometry, which allows you to cluster in major subgroups the immune phenotype in both phenotype, but also in some aspects of function. So you do a so-called functional immune phenotyping. What you definitely have to do, and that is something our lab had to learn, you're going into this sort of analysis in a more unbiased way. So it needs a multidimensional approach, and there is technologies to do so, and they are shown here, like Wisner and Spade. This is building clusters and thereby make sense out of this multiple data. And one approach is to subject this analysis now to this big national cohort and not showing data on this, but the idea is really finding an MS-specific signature or finding heterogeneity across the MS spectrum, which might be correlatable to future prognosis or response to therapy. And I think this is one of the big dreams of neuroimmunology. Can we personalize it, or can we measure it in peripheral blood and learn something about the future prognosis or just for the diagnosis? I'm not sure whether this video would show now. I think it does. So one problem that we have, I don't need a sound here, but it doesn't matter if it is. So what you see here is like a situation that kind of turns a little bit weird, and this is in the end the appearance of a cat killer. And this is exactly what happens if you take snapshots from, let's say, dynamic processes in immunology or in neurobiology, and this is the problem that neuropathologists have. They only get one piece, and they try to explain the world, what happened before and thereafter. But to profile and to really pinpoint who is the real culprit and what is not just guilt by circumstance, that's a more complex thing, and this is what we have achieved in profiling several paradigmatic neuroinflammatory diseases such as Rasmussen or SUSAC. So what you do, for example, you assess, which is meanwhile possible up to the single clone level, the immune repertoire. And the immune repertoire is characterized by T cell receptors that are unique, and you can actually evaluate those, and then you can actually compare a, let's say, normal Gaussian distribution, which I would assume most of us in the room should have, as opposite to what goes wrong in a particular disease. Well, if you look at something like this, this is one peak as opposite to nothing else, and that is a very strong indication that you have a dominating or very directed immune response against few or maybe even just one antigen. So that is one sort of analysis that is very, very instructive and can help you in defining what are those diseases directed against. And I mean, for those that are not in-depth experts in immunology, I mean, for T-cell malignancies, for example, or B-cell malignancies, that's very obvious. I mean, you have one clone that goes wrong and that peaks like hell. So this is how these technologies have been developed, and if you have a therapeutic approach and you eliminate all these clones and then it reappears, then you have a clear sign of a relapse of the malignancy. In autoimmunity, this is a little bit more complex because you have not just one clone that's going wrong, but you can also do patterns. And these patterns help you to better understand, is there a directed immune response? Another example is if you, for example, have a viral infection. During this phase of viral infection, like 60, 70, 80% of your immune cell is focusing on this virus. So you can measure that, and thereafter it normalizes again. So that's very helpful technology to understand whether you have a directed adaptive immune response as opposite to something Gaussian and normal. So this is one example of data that is not yet published, but I think it's very interesting, and this is how we understand is the immune system looking like in multiple sclerosis twins that are discoded for the disease. And to cut a long story short, what we did is using different methodological approaches and clustering in major immune subset, but what the result here shows, when we look at 142 different immune cell populations, is that, and that's actually quite drastic statement, that 98% of the signature that you measure in the periphery is dictated by your genetic background and by the environment. Only 1 to 2% is MS specific. So if you do this immune phenotyping, you could very easily see which of the two are the twins, but you couldn't see what is MS versus non-MS. So you can actually control very nicely in this setup against the genetic background, and we did all sorts of analysis. But that's not the end of the story. The end of the story led us to a novel finding, which is, I mean, this MS discordant twins, nonetheless, the non-affected twin has a much higher likelihood to develop later on MS. It's like 30 to 40%. And we found that some of those twins that clinically didn't have multiple sclerosis, they had subclinical inflammation on MRI. So that is not like clinically isolated syndrome or radiologically isolated syndrome. We call this subclinical neuroinflammation. So they have a higher risk, and obviously they are developing MS. And that is interesting that this prodromal multiple sclerosis is associated with some signatures that you can actually find in peripheral T cells. That obviously the development of multiple sclerosis within this, let's say, 1 to 2%, is really associated with a T cell signature. And we validated this in a cohort of early multiple sclerosis. And it's something that happens on mainly T cells and T memory cells. So this sort of an approach against a very well-controlled genetic and environmental background nonetheless already helped us to identify something like you could say MS is associated with something you can measure potentially in peripheral blood that is abnormal and can help you assessing developing multiple sclerosis. A second example is how are we analyzing cerebrospinal fluid, and how can this analysis instruct us to better understand neuropathological processes. And there is two major ways how we do that. One is we're using, let's say, available standard informations, but we're applying novel ways to analyze it. And the other approach is we're using novel technologies. So for both, I'm showing examples. So example one is you're using the informations you have. We are having the advantage of having a little bit a deeper information, which is flow cytometry. That is, let's say, yeah, multicolor histology, but on a cellular level, if you want to call it like that. And what we did, we used different diseases and did a clustering and looked, when you look at all these information, so you pool all the information and you do a dimensionality reduction, where would the dots cluster? And I mean, what this already nicely shows that relapsing MS and controls, blue dots versus red dots, they cluster differently. And why is this an interesting information? Well, the interesting information is that we feeded this analysis in an unblended way. So we didn't tell the analysis this is MS versus non-MS. We used the analysis to see would we have been able to tell, do these diseases cluster differently? And for MS versus non-MS, this might not be as relevant, but for other diseases where we don't understand really what the signature is, it is relevant. So neuromyelitis optica, other diseases such as autoimmune encephalitis and SUSAC. So this clustering analysis might help us to better distinguish distinct profiles in different neurological diseases even so. And that is actually the approach we have taken. And one other question is when we then restrict the analysis just to multiple sclerosis, so we're just using one disease, and then we ask ourselves, is such an approach in the position to distinguish different subtypes of multiple sclerosis, namely those that would be considered progressive multiple sclerosis as opposite to those that are mainly relapsing multiple sclerosis types? So this is a real question, because clinically you would like to identify or having a biomarker or a signature of progression as opposite to more immune activity. The result here is rather disappointing in that it shows that you have rather a immunological continuum. So with this analysis we were not able, using the parameters, and that were more than I was just showing, to distinguish clearly in a, let's say, more unsupervised and unbiased fashion those that progress as opposite to those that are relapsing. That means the immunology of multiple sclerosis seems to be a continuum and very similar across the complete spectrum, but, and that's maybe another important message, different from other diseases. So multiple sclerosis differs clearly from things like neuromyelitis optica and other diseases. And an additional story point is the second strategy. Can novel ways to analyze help us to better understand the underlying neuropathology? And one technology has attracted a lot of attention is single RNA-seq technology. So what you're doing here, all I was talking about previously was basically acting on the protein level. So it's expressed proteins that help us to characterize immune cell populations. This is acting on the mRNA level. So you're having a complete transcriptome, which is later then transcribed into proteins. But it gives you a very deep insight into the signature of cells, and what has developed over the last year is single RNA-seq approaches where you can actually dig into single cells, not just immune cells, any cell, and you get the transcriptome analysis. And what we achieved over the last years, we were able to do that from cerebrospinal fluid. So the technology has been established in tissues and in peripheral blood, but cerebrospinal fluid is pretty tough cookie to do, because I mean cells are very unhappy if you take them out of the cerebrospinal fluid. What we have done is now analysis of 25,000 single cells, and that is now the appeal. So you're reconstructing the, let's call it transcriptome, and thereby the immunome of the cerebrospinal fluid hypothesis-free. You understand the difference? So I mean, if you subject immune flow cytometry, you have to clearly say what I'm looking at. So you have to define, I'm looking for T cells, I'm looking for B cells. Here you're not defining anything, but you end up with something which we believe now is the transcriptomic and the signature of a cerebrospinal fluid. And what we did in this study is to compare now, hypothesis-free, the multiple sclerosis RNA-seq signature with controls, and what you end up seeing is differences, and those differences have partly been already known, or mainly they have been known, that you have alterations in the MS cerebrospinal fluid, in particular compartments and cell components such as B cells, plasma cells. So usually you don't have plasma cells in the cerebrospinal fluid, they show up in multiple sclerosis, but with this analysis we would not have initially looked for plasma cells. That's one message. So you get actually, you confirm and you identified novel informations with this deeper sort of an analysis. And with this information you go then into a next step, so you validate the results. Note that this is transcriptomic analysis, you then have to go for the protein level, so then apply things like flow cytometry or histochemistry to the immune cells. So the summary here for this first part is, I was trying to explain to you why the human neuroimmunome, by using rather unbiased and broad approaches, can help in better understanding novel novel immunopathogenic traits. I was talking about this twin approach, which helped us to better understand that most of these signatures that we're measuring is really dictated by genes and environment and not so much by the disease. But it nonetheless helps to measure something we call incipient or prodromal MS. We dig deep into one biocompartment which I think is very close to where the music plays, the cerebrospinal fluid, and we apply both novel ways to analyze with standard technologies, but also do novel technologies like RNA-seq. The second part is dedicated to leukocyte trafficking. Leukocyte trafficking has been recognized as a key element of, let's say, neuroimmunological diseases, mainly driven by multiple sclerosis, where there was always an assumption that leukocytes that traffic from outside into the central nervous system are essential in especially the early phases of the disease to promote disease activity. And what has been realized in a lot of literature, both in animal studies but some done also in humans, is that you have to go through different phases that in the end allow an immune cell to really traffic into the central nervous system. We have 2 approved therapeutic principles that kind of use this information that leukocytes trafficking into the central nervous system are bad for multiple sclerosis, and one has really instructed a lot about immunopathogenesis, and this is the monoclonal antibody natalizumab. Natalizumab has used the information that you need a certain receptor-ligand interaction that makes immune cells adhere to endothelium, and this is an essential step to then go further to make those cells migrate into the central nervous system. Fingolimod is another class of another principle which is working via the so-called S1P receptor system. And here it's not acting on the blood-brain barrier, it's rather acting in sequestering out immune cells in lymph nodes, but it's also affecting immune cell trafficking. When we are talking about trafficking, one clearly has to acknowledge it's not, there is no such thing as one blood-brain barrier. You have different trafficking routes into the central nervous system, and we have learned about that. And there is at least 3 that you should know. One is this classical thing that from the bloodstream, the arterial bloodstream, in the venous phase, you get this transcellular exit of leukocytes. But you have also migration via the choroid plexus, and you have a third one which is going via the meninges. So you have at least 3 trafficking routes. And the key question is, what are the receptors and the ligands always the same in all these different trafficking routes, and which of the trafficking routes are particularly relevant for immune surveillance as opposite to pathogenetic processes? And we have learned a lot about that when studying the CNS milieu, and again, this is a human study, in patients that are under therapy with natalizumab. So in natalizumab, the initial assumption was we're blocking out all immune cells coming into the central nervous system, and that is clearly not true. So what you're doing, you're blocking out major percentages of so-called central memory cells. So those are basically, you can't find them in the presence of natalizumab. And that is exactly what obviously drives a lot of the immune activity in the central nervous system, but you're not keeping out all immune cells, because that would actually lead to a breakdown of immune surveillance, as you would see it, for example, in patients with HIV. So that is not what we have seen. So natalizumab kind of maintains, in a way, immune surveillance to a large extent, but it has one problem, that is the antigen-specific association to a problem in controlling JC virus. And that is a very interesting case, one has to say. So despite the fact that you're neutralizing a trafficking system for many, many years, you're extremely good for multiple sclerosis, so it kind of dampens MS activity very, very efficiently. You don't really see any major immunological adverse events over many, many years, which shows you that obviously surveillance in organ compartments, including the central nervous system, is still maintained. But you have obviously the problem in controlling one virus, which is JC virus. That's, by the way, not only a problem of natalizumab. Basically, all immune therapies can do that, and obviously via different mechanism, but the association is probably most prominent, or is established most prominent in natalizumab. So we asked what happens with the CNS milieu in the presence of natalizumab, and what you see in this cartoon here is that a MS cerebrospinal fluid, you can actually tell. I mean, we are meanwhile very trained in interpreting these immune phenotypes from different conditions, and you could actually blindly tell, even our technicians could tell, well, this is MS. So they look quite characteristic. In the presence of natalizumab, they start to look normal again, particularly you're reducing the one type of bad guys, which is the central memory cell. So you're changing the milieu. And what we have done as a follow-up is, could this information help us better identifying those cells are under steady state condition necessary for maintaining immune surveillance. And we came up by identifying a chemokine receptor, which is CCR5, which obviously is very, very essential under, let's say, homeostatic conditions to bring immune cells into the central nervous system. And to cut a very long story short, what we did by using peripheral blood, by using cerebrospinal fluid, but also using tissue specimens from surgical interventions like epilepsy surgery, to identify those immune cells that you would find under non-pathological conditions in the central nervous system, and thereby assuming this is cells that do the job in immune surveying the brain. And what we found is one population which is a CCR5 high expressing effector memory cell population. And I'm not going through the experimental details, which are particularly interesting. I mean, they have a certain phenotypic signature. And note, those are cells that are surveying the brain under steady state conditions. And if you get rid of these cells or you dampen those cells, you have a problem in immune surveillance. So this is actually what we then identified, or what you can actually use this information. We also managed to better understand how these cells get into the central nervous system, because the mechanism is a different one than under inflammatory conditions. Just to illustrate that, so if you have a stroke, the blood-brain barrier is completely messed up, and everything from the bloodstream can enter the brain. So this is not a real directed migration into the brain, but the brain is full of inflammatory cells. If you have steady state conditions, there is no reason you would assume how an immune cell goes into the brain, but they do, and they do it via different processes. In this way, they are doing it in a transcellular diapedesis. So they squeeze themselves through cells, and then, and that's also interesting, they kind of stay in the central nervous system. So the concept is that they are migrating in, surveying, and they then are tissue resident cells. And in certain pathological conditions, such as HIV, you have a problem that those cells are heavily reduced. And that actually can explain why they have a higher number of infectious complications. In the presence of multiple sclerosis, those cells can also become of pathological relevance. So the story is that we identified a definable population that you could also call key population of immune surveillance, or tissue resident cells that are responsible for homeostatic immune surveillance. And why is this information so relevant? Well, one of the many implications is that if you're developing future, let's say, leukocyte trafficking agents, then you would actually try to get this this brilliant corridor of selectively affecting disease processes, beneficially affecting it, but not impeding immune surveillance. So call it, you could use this information to develop a more clever natalizumab, or a more selective interference also to other leukocyte populations using the information, and you could use this now also to better assess what happens if you manipulate for example, dosing regimens. I mean, extended dosing interval is a strategy, a potential strategy to reduce the risk of progressive multifocal leukoencephalopathy, but not at the same time losing efficacy of the leukocyte neutralization or trafficking neutralization process. And the question is, why is that? So what do you really change? Do you change the immune surveillance in the brain? Do you change the antigen-specific reactivity? So last slide and summary. We have come a long way, and we have learned a lot about leukocyte trafficking into the central nervous system, and why this is relevant. And it has a very well proven strong impact in especially the early phases of a very, very important neuroimmunological disease, multiple sclerosis, and its blockade with natalizumab has shown to have a very strong impact on disease activity. When you interfere with the immune system, but also interfere with leukocyte trafficking, you are more prone to develop immunological side effects, and one particular relevant and clinically relevant is progressive multifocal leukoencephalopathy that is actually lost control in JC virus immune surveillance. What we have learned is CD49D is the protein that is blocked by natalizumab, that you get compensatory mechanisms of immune surveillance. So the story is that you're not really losing immune surveillance in the presence of natalizumab. I didn't talk about prediction algorithm and biomarkers for progressive multifocal leukoencephalopathy. That might be something for the discussion, but I was keen on showing you this very novel data on how we identified a population that we believe is responsible for immune surveillance under steady state condition, and that information can help us to better understand what goes wrong in one or the other condition that affects immune surveillance or immune homeostasis. This is a lot of people that in my lab and in cooperative institutions have contributed, and I would like to especially thank Nicolas Schwab, who actually did this last study, and Gerd Meyer-Zerhörste, who is the one that established the RNA-seq technology in our lab. And my last slide, I hope you can see it, is the place I work. This is Muenster, which is a very, very lovely medieval city, a pearl of medieval city architecture. And whenever you happen to come to Germany, don't miss this spot. Thanks very much for your attention.
Fabulous. The one thing that most people in research complain is that doctors have an end point that they want to get to, and scientists start at the beginning and just explore. And you have beautifully demonstrated on multiple levels about what exploring in neuroimmunology is all about. Now, I'm going to open the floor to questions. Are there any questions coming from peripherally? In which case, anybody in the room who would like to ask Olga, please.
I have two questions. The first one might be very obvious. So you demonstrated, we presented here, your immune phenotyping, I understand, before treatment in MS patients. Have you looked at the changes after treatments, and if yes, what type of treatments, and what did you do?
Yeah. I didn't include that in the presentation, but what we do in parallel, and we did that basically with a lot of the treatments, is we call it established therapeutic cohort. So what happens to the immune system in the presence of a continuous treatment? And we've done that with basically all treatments, more or less. Very obvious things, what happens in the immune components in the presence of natalizumab, but maybe also very interesting what happens after pulsed immune reconstitution therapy. So what is the phenomenon of immune repopulation? We did that would have just been too much. there is specific signatures that you could identify, and you could learn from that in terms of biological responses, but possibly also pathological prediction responses. So a very obvious question is, could the peripheral immune signature instruct you who is at risk for developing secondary autoimmunity?
Will you talk about it at lectures?
No. Well, bits and pieces have been published. I'm just pondering. We have some posters, I think, on this therapeutic responses and the immune phenotype. Yeah.
And the second question is with respect to the predictors of PML on naturalism. I know that a few years ago you presented data and that everyone thought that it was an answer, that we will be able to identify patients who will develop PML. So do you think that, I reckon that the interest is not lost, so you're still trying to discover this mechanism. Do you think it will have clinical implications, identifying the CD49s when testing patients for its really activation, and see whether or not it might predict further PML development?
Yeah, I mean, in 2013, our group with this immune phenotyping identified L-selectin, which is CD62L, which is a surface marker also used in classical immunology to identify certain immune cell subsets, was associated, the drop of L-selectin was associated with a future risk to develop PML. So we believed it was a biomarker that could be used in daily practice, and we really established it also for the use in daily practice. Problem is that it is a quite complicated test, because you have to subject cells, you have to freeze them, you have to thaw them, and then you do the flow cytometry. And there was a lot of discussion in the community, but I didn't include it today, but we have meanwhile finished a prospective validation of this parameter, and it shows to be really true that you have a certain threshold that you lose this molecule while on treatment, and if you lose it under a certain threshold, your future risk increases substantially, and that could be very helpful in addition to JC antibody and JC index evaluation. And the very beautiful aspect in this biomarker is that if you apply this extended dose interval, L-selectin recovers. So you're seeing this as a better biomarker than CD49, because the saturation of CD49 is not that responsive to extended dose intervals. So L-selectin is really nicely responding. So it could be a marker or a signature very useful also in clinical terms.
But is there any work supported by Biogen in the way that it might become a commercial test?
Well, the problem is that that is also a long story. Biogen knows about that, knows very well about that. For Biogen, the test is simply too complicated to offer that commercially. So that was our hope, to say, well, you have something that is probably better or in addition useful than the JC antibody test, but the JC antibody test is a simple ELISA. It's not as simple, and this is a more complex technology that works, but it's not so easy commercializable.
Thank you. I have actually another question.
Yeah.
Just get to the, so talking about immunophenotyping, and we're all looking for markers to predict treatment failures, and the Helmut and the other, we're working on that as well. So do you think, at which point you need to retest patient with the CSF immunophenotyping after treatment, and at which point do you think, or at least your data is showing that you can predict treatment failure subclinically, or can you predict it subclinically?
Yeah, it's pretty relevant and interesting question. I have to potentially put some water into the wine in a way that I say, okay, one assumption is that, or one prerequisite would be that the peripheral blood would really show you exactly what happens in the central nervous system. And I'm not so sure this is the case. I would say you can very, very nicely define the biological response to certain drugs that you apply. Whether this is one-on-one correlating with a clinical response, that's another story, you know. And here is, I think, the limitation. So we hope we learn about that in this national MS cohort, how well the mode of action and the biological response really correlates with the clinical response. I mean, there's a lot of confounders to that. I mean, one very instructive example that I always used to say is, look at natalizumab non-responders. I mean, you have a drug that works pretty strongly, and if here people have relapses, then you know what's going wrong. With interferons and other stuff, it's much more difficult, because I mean, it could be natural fluctuations, it could be just too moderate efficacy. But with the high efficacy treatments, you would say it's like an extreme response, and if you have a non-response, that could be something that is very telling.
I have one quick question. That twin study is fascinating. So you potentially can predict, because when we look at pre-diagnosis of Alzheimer's disease and pre-Alzheimer's treatments, if we can identify a cohort of people who we can treat before they have clinical MS, is this possible from the research you're doing, or you're hoping it will be?
Well, this is one implication. You absolutely got that right. So, I mean, if you have a genetic risk situation, you would say, well, go into the MR every other year, or we do some sort of immunological phenotyping, assuming that that could tell you that something's going wrong now and you're at risk. But I think that's the implication. So is there a way to predict that something's going wrong? And that might be one sort of applying this data to say, okay, we might have a possibility to assess whether this signature in this few subpopulations of immune cells shows you that you're putatively at risk.
And then, of course, the ultimate question is what actually causes that person to develop MS? We're no closer.
That's a fair point, I have to say. You're right. I mean, especially in the twins, you would ask yourself, so what is this factor that eventually leads to the loss of immune tolerance in one individual and not the other, you know?
Do we have any clues?
It's I mean, to my opinion, it's pretty much of a stochastic thing. I mean, much more than in other diseases like stroke or so. It's a stochastic interaction of the immune system influenced by many environmental triggers. And for example, even in twins, one twin would have more often a common cold or more often an infection, and that actually breaks tolerance as opposite to the other one. So it's tiny little hits to the system that eventually makes it breaking down. I don't think that we identify the one hit in multiple sclerosis at all. That was the big hope, the infectious agents for multiple sclerosis. I think it's many little hits that in the end lead to a stochastical breakdown of the immune regulatory network structure.
Can I thank you? That
Yes.
was absolutely fabulous. Thank you so much, and thank you to everyone for attending, and to the distant people who are looking by. I believe we've got no questions from out there.
No questions.
They're all overwhelmed with the information you provided, but thank you very much.
Okay. You're welcome.